Listen-only mode.
Who don't know me, I'm on faculty with the Family Medicine Residency of Western Montana here in Missoula, and this is Justin Perry. He's one of our third-year residents. We are going to be talking a little bit today about healthcare in developing countries, specifically in Ethiopia, and the healthcare training with a focus on primary care and family medicine. And this is based in part on a recent trip that we took to Ethiopia in May and June of this year. Dr. Perry and myself, along with representatives from 4 different departments from the University of Montana in the health professions, who brought faculty and students, all went over to Gondar, Ethiopia, as a sort of exchange to work with their different departments in their university training center, their university hospital, and we'll talk a little bit more detail about that. But just a little background for you all about us. Before joining the faculty at the residency program here, I had lived and worked in small town Alaska, both on and off the road system for a while, and had spent several volunteer trips, or had spent some time doing several volunteer trips overseas, everywhere from Borneo, Indonesian Borneo, to Ethiopia on one trip prior, and a couple of other African countries. Justin, prior to going into medicine, this is his second career. He was an engineer prior to this, and spent quite a bit of time in Kenya working on some projects there as part of that as well. And so when we were starting to set up the opportunity to develop some international training and some global health training for our residents, Justin was one of the ones who jumped at the opportunity to go with us in this first preliminary trip. So with that, I'm going to hand things over to Justin so he can talk with you a little bit more about the specifics in Ethiopia.
Okay, can you guys hear me with this mic? Yeah. Anyways, I'm just going to go over the objectives. Main things we're going to be talking about is like the state of health care in Ethiopia. I'm going to share some of my clinical experiences I had while I was there, and then go into a discussion why family medicine is important in Ethiopia, and then share some things we noticed just in some of the training differences between the U.S. and Ethiopia, and then also some of the lessons learned. As you can see, then also just talk a little bit more about that multidisciplinary trip with the different health professionals and students from the University of Montana, and then why do we want to be involved with this. We just mentioned, as Dr. Bell just mentioned, we were over in Ethiopia, and just want to give you a little bit of background about Ethiopia before we get started. I don't know if everyone knows, but Ethiopia is in Africa, but it's over here in Eastern Africa. Pretty close to some of the Middle Eastern countries, and that location's very interesting. I mean, just some of the past history. Ethiopia is home to Lucy, who's like the oldest human remains, is located in a museum in Addis Ababa, and supposedly this is where the humans came from, is the idea in Ethiopia. And there's also a lot of history just with like the Queen of Sheba. I mean, she is from Ethiopia, and so there's a lot of, within the religion in parts of Ethiopia, a lot of Jewish-Israeli ties there, and so there's like a lot of cool history that goes on in this country. And then here, just kind of give you a map. It's kind of looks a little blurry to me, but maybe it isn't. Right in the center here is Addis Ababa, and that's the capital city, and it's a city of a few million people. And then we were located up here in Gondar, and that's up, it's here in the northern part, and it's a city of a few 100,000 people. And so let's go on here. And then I just included this picture just kind of show you what Ethiopia looked like, at least the Ethiopia we saw. It's a different picture than I had growing up. I remember as a child growing up, and Ethiopia was always on the news, and it was these starving kids and this desert landscape look and just brown dirt. So that's the picture I always had of Ethiopia, and got there, and it was very surprising to see just how lush it was and mountainous, and we were like at a very high elevation where we were at. I think Gondar's like at 7,000 feet of elevation, and there was areas we went into the mountains that just felt like highlands. And so it was a different experience. It's a place worth checking out and traveling to someday if you get an opportunity, because it was very beautiful and a lot of just a cool history there. Now I'm going to just kind of go in just to the healthcare in Ethiopia, just kind of give you some of the differences. According to the UN Human Development Index, which I didn't look at what all the characteristics they go by there to score countries, but Ethiopia ranks 174th of 187, you know. So, I mean, so they definitely, they have a lot of work to do in improving their healthcare system. Of all the births in the country, they figure that only about 10% of births are attended by trained personnel. A lot of this is because of lack of physicians or midwives or whatever, you know, people that are trained to help, but also like 80-some% of the population lives in very rural areas. There's no good infrastructure for transportation, and people would have to walk to care. Some of it's because they believe more in traditional healers, and so some of them maybe are resistant to having providers and people there to help them out with their births. But it's because of this low percentage of births being attended, there's a big problem with fistulas in that country. And I don't know if you guys were aware, but earlier this last year, last spring, they actually had a showing of a film over at the Roxy called A Walk to Beautiful, and it talks about like the fistulas, and it was a very good movie. So if you ever had an interesting, it's a documentary, it'd be worth like watching sometime, A Walk to Beautiful, just to give you a better history or picture of what goes on with the women that are suffering with fistula. And then another thing is just like, you know, it's hard to believe, but the maternal mortality rate is 590 to 100,000 live births. For a relationship here in the U.S., it's about like 20, 21. More women have mortality during birth. So it's a significant, you know, significantly harder time on the women when during birth there. Another thing that's interesting, they have rural hospitals, and some of these rural hospitals serve a huge population, but they're run by GPs. And just so you know, a GP there is someone that's finished medical school but has no residency training. And some of the hospitals, I don't even know if they even always have GPs, you know, there. In 2009, these statistics are a little old, but there was only 2,150 physicians in Ethiopia. 47% were GPs. You know, so almost half their physician force doesn't even have residency training. And of those physicians, most are in the urban areas, but 80-some% live in the rural areas. So there's not a lot of good health care throughout the country. And the Ethiopian government's recognized this, and so they've decided to really develop family medicine training to see if they can help with the need. And that's significant. I mean, Ethiopia has decided to start a lot of new medical schools, and they've started these up, and now they're trying to start new residencies just to get a lot of people out there, a big task force out there. And Dr. Bell and I talked about it before, some of the attitude, I think, with Ethiopia is the attitude, let's just get a lot of people out there that have some training, even if it's not the most ideal training, at least to have some training versus no training. And so they're just going to try to flood it currently and try to get a lot of new physicians out there. And as far as family medicine goes, there's only one current program in the country. Well, only one. As of 2 weeks ago, there's two. But there was only one family medicine residency program, that's the Addis Ababa, and they just graduated the first class this past year with 7 physicians. And now the new physician residency starting in Gondar just actually started 2 weeks ago with 3 residents. This picture here I just wanted to show you, just kind of when I saw that, it made me think of a few things. And the one thing I thought about, I mean, they do have really smart doctors. They have, you know, really intelligent people there that really care, trying hard, but they just have different resources than us. And I saw real ambulances too, but this was just a picture to show us the different resources they have there. Now I'm just going to talk about some of the clinical experiences I experienced just while I was there, because we were there for about 3 weeks. I had the opportunity to round with the internal medicine, the OB, and the peds. And I mean, I was really impressed with their attendings and stuff. They're very intelligent, very sharp, well-trained people. And so their lack in healthcare isn't because they don't have smart, intelligent people. It's just resources. The one thing that I thought was very interesting was no matter what comes in the hospital and the wards, TB and malaria are on the differential. If a DKA comes in, it's TB and malaria ruling those out. And that was just, you know, coming from the U.S., you never see those diseases. So that was just a cool, I guess, learning point, or it was kind of interesting just to see that was always a workup for those 2 diseases in this country. Because most people that are hospitalized in Ethiopia aren't because of chronic illness, it's more because of infectious disease. And I had an opportunity to see a couple of patients that had visceral, I always have a hard time saying this word, leishmaniasis. I said it maybe? I'll just say VL from now on. But anyway, during one of the rounds, we had a patient that were suspected to have that, and the attending's talking about doing a splenic aspiration. And I just remember the whole time, like, did I miss that in med school? What is that about? Like, I've never seen that in St. Pat's. I mean, that was what was going through my head. And I finally, there's all these med students, and I had to kind of raise my hand and ask, like, what is a splenic aspiration? And there they just do that bedside. In Ethiopia, it's not, you don't go to ultrasound, you don't have a surgery team. They just do a needle, and they check for antibodies in the spleen to rule in if it's VL. And so it was just very interesting. I mean, the residents are expected to be able to do bedside splenic aspirations. I also had the opportunity to follow an intern around. Intern there is a MS6, so there's 6 year med school. And it was impressive. It was impressive, his knowledge base. It was, I mean, he just had so much stuff memorized. He was very sharp. But it was impressive to see how the interns were the workhorses of the hospital. They did everything. They don't have phlebotomists. They don't have all this other staff. Like, anything that had to be done, they were running around doing. If a patient needed a lab drawn, he would write out this order for the family member, hand it to him, they'd go pay for it, bring back the slip. He'd then go get the needles, he would draw the blood, then we'd walk across the hospital, we would take it to the lab, we'd go do other stuff, then we'd walk back to the lab later on, looking for the results, get the result, take it to the chart. I mean, the interns, it was very tedious. And when I told them how our system works, I mean, they were just shocked, like, you have these people that do all this. And so I'm appreciative with the resources we have, but I was kind of envious of him because his understanding of how a hospital works is so much greater than our training. And so I really feel their physicians really know the in and out of every component of the care in the hospitals. And that's just a point I wanted to share because I thought it was just really neat that they understand just how everything works. And then I had a chance to also attend some medical conferences there pretty regularly most mornings. It'd be like the internal medicine going over cases. The big things I learned during these clinical experiences was just the lack of resources available. The hospital we were at Gondar, it's a big regional hospital, and it serves somewhere, I mean, a catchment area of like 5 million people. And in that whole hospital, there's one echo. And I remember once we had to have a patient that we had suspected endocarditis, and so we wanted to get an echo done, but you don't just order an echo. It's not like a click of the button like it is here. We had to track down the cardiologist and get permission to get an echo on this patient because that resource is so valuable. So it's just, differences with care, like how you have to approach problems there because resources are limited. You really have to prioritize what they can use. They have very minimal nursing support. In a ward where there's maybe 20 beds, there might be a nurse there. Most of the care is taken care of by family, and so they call them the family attendings. So the family's feeding them, bathing them, and doing everything like that. There isn't the nursing support. And the wards are very cramped. I mean, in a room a third this size, there'd be 20 beds. And there's no walls, no dividers. When we would be rounding, you'd be standing at one bed and you would just turn around, pivot, and you'd be at the next bed. And then just resources as far as infrastructure, a poor electrical grid. I mean, even in this bigger city, for say Gondar in that country, they couldn't always count on the electricity working regularly. So, I mean, there's just a lot of limitations with the equipment they can use because of that. And anyway, and just different exams. I got to see the OB residents using a fetoscope. I'd heard about it, never seen one before. It was just amazing, like seeing them use that, but also how labor intensive it was to monitor, pregnant women with a fetoscope instead of having like the strips like we have. And they just did very detailed exams. I would see, the residents, like med students, measuring with tape measure every little part of the body and stuff. And to me, it seemed ridiculous, but I was like, why are they going so detailed? But maybe there's a lot to be learned from that too, because they can't use as many imaging studies as we can, and that was more important to find little differences. This is just a picture of the hospital, just to show you that it wasn't one big building. I mean, there was probably 100 buildings on this campus, and the wards were just little buildings, and it was on a big hillside, and so to go from the lab to stuff, I mean, the one day with the intern, I bet I walked 3 or 4 miles in the hot sun, just all over the place trying to take care of stuff. Just kind of show you more of the campus there. And then we also had an opportunity to go visit, just for a day, we got to go visit one of the district hospitals. And it was surprising to see, because this district hospital had a catchment area of 500,000 people, but it's no larger than the hospital you'd probably see in, not even Polson, I mean small town. I grew up in Fort Bend, Montana, a little town of 1,500, and this hospital was probably smaller than the hospital in my hometown. And yet this is serving 500,000 people. And now I'm just going to talk about why family medicine in Ethiopia. The government really wants to be able to provide physicians for these district hospitals. And because right now, as I mentioned earlier, there's only a GP, who is just a medical student that just graduated from medical school, is the main provider. Occasionally they have physicians coming in, but I mean, they just don't, they're really manned by, there's rural health workers there, there's like people that have, midwives, there's people like that at these rural hospitals, but there's just very limited resources as far as people that are trained to run these facilities. And then in their family medicine curriculum in particular, they have greater emphasis on public health. It's not so much, I mean, it's going to be definitely being good clinicians, but it's also very much about improving public health and having that as a big part of their training. And a big portion, I think, why they want family medicine too, because family medicine is trained in OB, and so they want to be able to improve the maternal outcomes during birth by having these physicians in place. And as I kind of mentioned, I mean, the family medicine's role would be the leader of these teams, because in these rural areas, you have these people that just graduated high school and they get like a year of training and they're like a health worker. And so, and they have these out and they have these little sub-little clinics, and that's, you just have a health worker there running those with just a year of training. So, and then having these physicians out there could help improve, their care and their training. Obstacles with family medicine, as of just, a couple years ago, there was no such thing as family medicine in this country. And they've only had they only have 7 family docs that graduated from a residency there. And so right now, the obstacle is what is family medicine? Because you have these medical, and it's not so much on the population, but it's within people choosing this career, because right now you have all these medical students and they've never even heard of family medicine. And so that's going to be a big challenge, is convincing people to go into this specialty. And where these district hospitals aren't desirable places to live. I think a rural area here in the United States is very desirable, like an easier, simpler life. Maybe it's in the mountains, you can enjoy your outdoor activities, but we still have the same quality of life, as far as we still have electricity, we have running water, and access to stuff when you're in a rural area. In Ethiopia, if you're stuck out in this district hospital in this rural area, all of a sudden your lifestyle is dramatically changed from living in Addis Ababa. Now you no longer have, the infrastructure, you don't have electricity, and so it's going to be a challenge getting family medicine people to go there, because if they know they're going to get placed at the district hospital, it's going to be like a rougher life. And currently there is no Ethiopian really faculty, family medicine faculty. They're going to be kind of counting on foreigners to kind of do the training until they're able to develop their own faculty. And then just anytime there's a training place, just trying to get the buy-in with other specialties to really trying to push the role of family medicine in this country. And then I was actually going to just hand this off to Darin here to talk about the family medicine residency in Gondar.
Yeah, so just wanted to spend a minute or so talking about the process that this is going through. So clearly, as Justin was pointing out, there's a significant issue with access to medicine in general throughout the country, an even greater issue with access to, well, I guess along the same lines, access to primary care. As he mentioned, they have health extension workers, which may have as little as a year or even less of training, and that may be all that people have access to in terms of getting any sort of health care. Their emphasis and their focus at this point in time is primarily on public health. They have a huge nationwide push for boosting immunization rates throughout the country. And so much of their time is taken up with making sure that they're getting access to all of the villagers in their surrounding area. And the village, so the health posts that they have, and one of those buildings in the prior pictures was of a health post we went and visited, they'll generally have one station for a larger village in a very large surrounding geographic area with small villages all around it. And they may be 15, 20 miles from some of the outlying smaller surrounding villages, plus all the farms in between. And so they spent an enormous amount of time when we were discussing with the health extension workers, just keeping tabs, maps of the areas that they have to keep track of, charts on the walls stating what percentage of what village have received their immunizations, what percentage have latrines that are available for use, and what percentage have access to clean water, not running water, just clean water. And so in large part, they just don't have time to be providing care to for medical problems as they come up. There's a dramatic underutilization of the healthcare system within the country as well, and this is along the same lines because people know that they don't have anywhere to go, and if they do go to one of these health posts, there's very limited resources available at them. They do have a small pharmacy at each of the health posts with some things, basic things like antibiotics. There was a cool, and we should have put a picture in here, but there was a interesting little setup. It looked like the two health extension workers we were talking to had a little tea set up ready for them for lunchtime, but it was their oral rehydration station, so that if anybody, particularly kids, come in with severe dehydration from gastrointestinal illnesses, then they have their little packets of oral rehydration salts and their containers, their pitchers of water, which are all just covered with cheesecloth to keep the flies off, essentially. And they can pull that off and provide some oral rehydration, which is one of the largest issues that they're able to deal with. Simple things like infections, they can try and clinically diagnose pneumonias and treat them with antibiotics, but their ability to actually identify and treat these processes are very, very limited. And so along these lines, the government has said we need to find some way to provide better general care to the population so that they have access to higher quality care. This is a trend that's been going on throughout Africa for quite some time. Kind of started within South Africa and then has moved into Malawi and Kenya, and I believe Tanzania as well, and so Ethiopia is following along this trend as well, to improve access to primary care. And the general consensus has been they need better trained generalists, which is where family medicine fits in. And so the government essentially mandated that to the medical community that you're going to start family medicine training. Like Justin said, there was absolutely no familiarity with family medicine prior to this, and so nobody really had any idea how to do it. In Addis Ababa, they set up the first residency training program. It was established 4 years ago now, and they graduated their first classes, as Justin had mentioned, in February, of 7 residents. It was largely set up and operated by foreign nationals who came in, family physicians who came in and assisted. There is one physician in particular from Toronto, Canada, who spent a couple of years there helping to train, and he's since moved back to Canada, is now in Calgary. But at this point of that training program, they have 2 physicians who actually graduated from my residency program that I went to up in Alaska the year before I arrived there, who are now living semi-long-term in Addis, helping to keep that program up and going. That's it. That's all they've got at this point. The government said we need more. So they've been mandated both at the University of Gondar and at the University of Jima, which is in the southwest portion of the country, to start up the 2nd and 3rd family medicine residency program. We became connected with the University of Gondar because of relationships between the University of Montana and University of Gondar through other departments. So our purpose in going over for Justin and myself was to kind of provide an evaluation of where they were standing in terms of their preparation to start their family medicine residency program and how this was going to work in the light of this government mandate to get things up and running. At the time, it was actually really interesting. This was May and June. They had initially been planning to start the residency and had been told that they would start the residency last September, and that didn't happen. That kind of fell through. So then they were thinking they might start it in January, and then that didn't happen. And then they were thinking maybe in July, and that's what the government was really pushing for, but we were there in May and June. They're like, yeah, that's probably not going to happen either. And then, as some of you may be aware, there's some turmoil and political unrest that's going on in Ethiopia right now, which we can talk about a little bit more in a minute. But things kept getting delayed and delayed and delayed. And so the last we had heard when we left was that they were probably going to start in September. However, by the time we, throughout email contact throughout the summer, it wasn't entirely clear when things were actually going to start up until we received an email just at the end of last week saying, a week ago we started up our program and we've got 3 residents. So because of the challenges that Justin put forward, this has been an ongoing, very difficult process. It's housed in the Department of Internal Medicine right now, and part of that has been, or that's been one of the challenges, is that They have the physicians there who are working on this really buy into the idea of needing better primary care and better generalist care, because in these rural areas you have to have someone who can deal with anything that walks through the door, at least at some level, but they're not trained in that. So it's when you have an internist and I have to say it's Dr. Ermias who's running this from their internal medicine department, and he is very, very dedicated and very much believes in the process of getting better generalists. But he doesn't deal with children. He doesn't deal with obstetrics. He doesn't deal with these other medical problems. And so it's been challenging for him to try and develop relationships and establish the connections where other people will buy in to help train the residents that he's starting. In addition, the 7 residents that graduated from University of Addis Ababa were all contracted out to work at other hospitals, as opposed to come helping to establish and teaching at other residency programs as they developed. And the reason for this is all of the trainees in Ethiopia are on their own for payment for their education. And the way that tends to happen is a hospital, a clinic, or a location will sponsor a resident. And they'll say, we'll pay for your residency education, but then you've got to give us X number of years of work in payment. It's similar to the National Health Services Corps going through a medical school, except it's set up by individual clinics and individual hospitals throughout the country. And so all of them, we discussed this when we were over there, all of them had obligations to go work at other hospitals, and they weren't able to get any of them to come to teach in Gondar as they're trying to get this program started up. And so that was one of the big needs that they continuously talk with us about, which again we'll touch on a little bit more down the road. So in essence, you had a bunch of physicians who were unfamiliar with family medicine, unfamiliar with anything beyond just having GPs go out and man these hospitals after they're done with medical school, and they were being told, you have to set up these programs and you have to get them running and you have to get them going in this time frame. With, as Justin had mentioned, the philosophy, if we can just get a whole bunch of people trained, we can worry about the quality later. And so that's made things, I think, a bit challenging for those who are trying to set up the programs and say, we want to produce a high-quality product, we want to have doctors who know what they're doing and be able to get out and appropriately manage health conditions in these rural areas, when the philosophy is more like, we're going to start up 13 new medical schools in the last 5 years. We don't really have residency training spots for all of these people, but we just need people with some level of training out there. And so that's been producing some challenges as well.
Now I was just going to share a few things just about some of the training differences, which I've kind of alluded to earlier. So in their medical training, they just have a 6-year medical school program straight out of high school. In your 6th year, as an MS6, that is considered your intern year. And then following graduation, pretty much everyone, you have to do some GP requirement. It could be a year or 4 years where you're just working as a general practitioner with no residency training. And then Dr. Bell mentioned, and then you're contracted out, and that's how the residencies are paid for. You don't just get to go pick your job once you've finished residency. And then I just kind of include this picture. So here's that fetoscope, and it's just showing you, they just have different resources, different tools than we do to do their training. And I still have never used a fetoscope. I didn't get an opportunity to do that, but it just seems so labor intensive. Lessons learned going to Ethiopia, and that's actually a real picture. That isn't just something pulled off the internet. Stuff's different. Stuff's definitely different there. Just in Ethiopian culture, it was kind of a challenge just for us setting up meetings and trying to organize stuff as a foreign country going over there. Is punctuality is very different. If we say something starts at 8 o'clock, you show up and expect stuff to start at 8, or maybe someone shows in at 8:02. In Ethiopia, if someone told you we're going to have a meeting at 8, it might be at 9, it might be at 10. So there's a lot of just waiting around. You just never really knew what was going on. So when as a visiting, people coming in, it can be really a challenge moving forward if they don't have that expectation and that understanding. That's how the country works. There's also the Ethiopian clock. So say, for instance, it's 10 o'clock in, well, it's not say 10. Say it's 12 o'clock in Eastern Africa, in the time zone that Ethiopia is in. Ethiopia has its own clock where they base it. It's a 12-hour clock based on the sun. And so it's 6 hours difference. And so when people wouldn't show up at a meeting, and you're expecting to meet at 8, then you're like, well, are they just running late because they're really just going to show up at 9? Or is it because 8 is actually 2 in their head? You know what I mean? So there's a lot of confusion going on, so you never knew if you were missing the meeting, if you misunderstood what they meant by 8 o'clock. And so that'll be always a challenge, I think, moving forward. But just I think people need to understand that if they go work in Ethiopia, that will be a challenge. And they just work at a different pace. We had a visiting professor here, came here this last spring, and the residency and University of Montana had all these meetings set up for him, had this packed schedule, and I think it overwhelmed him because I don't think Ethiopians work that way. They don't pack in something scheduled every minute of the day, where we did here. So I think it kind of, you know, he was, I think, taken back. But the same thing, when we showed up there, we had this expectation that they're going to have stuff planned for us and we're going to go, and we show up there and day by day it's like, okay, what are we doing today? You know, it's like, how do we meet with people? And so, I mean, I guess the biggest thing is just expectations moving forward if we're going to continue with the University of Montana, continue to work with Gondar University. And then the one thing I talk about expectations, but then the incubator. I'm just going to show a picture. When we went up to the district hospital, and this was just like a big lesson or like a point that stood out to me while I was there, there was this brand new incubator out at the district hospital just sitting in a storage room. It's not that they didn't know how to use it or that they were appreciative of this gift. Some foreign government or aid organization bought them this incubator. It was sitting there because the hospital it got sent to didn't have the electrical grid to run it. And that just made me think about, you know, our role moving forward if we're going to help this country. You know, don't us just expect like, hey, we're going to help you this way. We need to make sure when we are offering help in any foreign country, for instance, that you're meeting them with the needs they need. They didn't need an incubator. They probably needed 50 fetoscopes. You know, I mean, they need other resources because send them an incubator, they don't have the electrical grid to run that, so it's just wasted equipment just sitting there. And so I think going forward, I mean, if you're ever going to donate equipment to foreign countries like that, you should ask them, what do you need? Not just assume that they'll like this fancy toy that we can send them. But the same way with our help moving forward, like if we're going to send faculty there to train, it shouldn't just be our idea of what are we going to offer the training. We should really be making sure that we're giving them the training they want. And then we're just going to, Darin's going to talk about the multidisciplinary team here a little bit more.
So just a little talk about the trip that we took specifically. This was set up through the University of Montana. So there had been an ongoing developing relationship between UM and University of Gondar. It was started several years ago and has been developed most efficiently and effectively through the Department of Psychology, actually, and there have been a number of people who have taken trips over there and helped to teach at the University of Gondar. Through the efforts of several of these people, there has been a memorandum of understanding set up between the two universities to exchange faculty and trainees and help to work together and on a number of collaborative projects. That just got signed within this last year, and this trip was actually one of the first large manifestations of that. The College of Health Professions and Biomedical Sciences at UM really kind of took this opportunity to say, well, we want to do two things. One, we want to see if we can firmly establish a relationship and help provide for opportunities for both us and for them to collaborate on a number of research projects and training initiatives, but we also wanted to provide an improvement in our interprofessional education among the college and the different departments, and that includes the family medicine residency as that's the department that we're technically housed under. And this has been an ongoing developing process, not only at UM, but throughout health education in the United States, and in fact many specific organizations and groups that accredit, say, nursing or pharmacy or physical therapy, all are now inserting requirements into their educational curriculum for their accreditation process, requiring that you have some sort of interprofessional education. So we felt that this would be a great opportunity to take learners from different health professions over into an environment that would be unfamiliar to most of them and have them work together as a team to try and A, gain some valuable experience in terms of global health, B, find out what sort of collaborative efforts we can continue with down the road, and C, really get a better sense of how do you work together on an interdisciplinary team which ultimately will theoretically lead down the road to improved healthcare and health outcomes for patients here, as well as people start to work together in teams better. So for this particular group, that's the entire group. That was actually taken in Lalabella, which is, for those of you who aren't aware, an absolutely amazing location. It's got some of the largest monolithic rock-hewn churches in the world. So you've got churches that are carved out of solid granite blocks that basically, if the blocks aren't sitting above the ground, they just carve right down into the ground, and they have these huge cathedrals that are all carved out of one solid piece of rock. So we spent one of our weekends there. But these are the representatives from the team that went. So the family medicine residency, Dr. Perry and myself, were the representatives on that. Physical therapy had 3 students and 1 faculty member. Pharmacy had 3 students and 1 faculty member, and then there was 1 psychology faculty member who, and they were not able to bring a student along with them. We also had public health very heavily involved in the planning process and setting up, but they were unable to get any of their faculty or students to go along with us on this trip. So as part of this, we did several things to try and improve the interaction and the teamwork, both before we went on the trip and while we were there. Before we went, we had a series of meetings after we'd gone through the initial planning stages among the faculty to decide what departments could actually go and how could we set this up and make this a feasible opportunity for the learners as well. Then throughout the 3 months prior to departing, we had a series of meetings with all of the students, residents, and faculty who were going, as well as at least one of the meetings, we had a visiting professor from Ethiopia who joined in. And these were geared toward very specific preparatory things. So we had one that was geared toward what sort of immunizations and what sort of healthcare do you need for yourself prior to going over, or what sort of things should you be thinking about for just taking care of ourselves while we were there. We had another one on social and cultural differences between Ethiopia and the United States, and that's where the Ababo, the visiting professor from public health, came and gave led a very good discussion about the things that you might expect and cultural differences you might have there. And then we had some just logistical type meetings, how to pack and that sort of thing. But the goal of this was to actually try and get the learners interacting with each other prior to this trip, so that we weren't a group of strangers going over all thrown into this unusual and different environment for us. Then once we were over there, we had structured weekly meetings where we debriefed with all of the different groups of people who were there. And part of that process was just talking about what we were experiencing and what we were going through on a day-to-day basis. We had a number of activities and events that we did together, which Justin's going to talk about a little bit more here in a bit. But a lot of the time, the pharmacy students and faculty were working with the Department of Pharmacy. Justin and I spent much of our time with the internal medicine department and rotating through other medical departments. The physical therapists were with the physical therapy department. So then we get back together and talk about what's different between the 2 environments, what's different in the different departments, and learn from each other. And it was actually really interesting and kind of eye-opening for some of the students, I believe, in terms of just finding out not only what are the differences between Ethiopia and the United States, but what are the differences and what are the capabilities within each of these different departments. Justin noted up here that PT does home assessments. This was one of the things I think that, and I'll let him talk about this a little bit more, one of the things that was just kind of surprising that wasn't aware of previously, because in our little siloed training experiences, we don't necessarily get a whole lot of exposure to what other departments are involved in and what they do.
Yeah, because I mean, doing my medical training, I feel like I'm pretty familiar with like pharmacy does. I mean, we get to round with them on my ICU block. We have a pharmacy faculty on our residency faculty. But I always think of physical therapy as, oh, you blow your knee out, or maybe rehab stuff. But it was interesting there in Ethiopia, the physical therapists there, they go and do these home assessments in very rural areas. And they find like kids that have different disorders or diseases, they're going to be very weakened, and they go in and they teach the parents and set up equipment there within the homes so they could help rehabilitate these children just at home. So because there's no way in these rural areas they can be going to physical therapy appointments. And so it was just interesting to me to see that physical therapy had this in-home part of it. And then like talking to the physical therapy students here, I mean, they were actually taught to do stuff like that. And it was eye-opening to me, and it was good for me to be aware of what some of the other professionals do within their careers, and so that I can maybe access those resources in the future. And just showing a couple of pictures here, like this psychology faculty member. She was really involved with a lot of schools and really focused on that. So we had the opportunity to visit some schools while we were there, and like we went to a deaf and blind school, and just seeing the resources they had there, and just I was really impressed actually there in Ethiopia, like with the school that we had visited and just the talented members there. I mean, there was, deaf people there that were teachers, and they were like, this one guy had drawn all these drawings. I just took a picture of it on the wall and showing them how to do sign language, and he took the time to draw this all out for his students so that they could learn how to sign. These were these desks that actually one of the deaf former students had built, and he was really excited about this project. And these desks are adjustable desks for people with cerebral palsy. And so we got to tour that, and then this is all part of the community health or school there within Gondar University was doing a lot of these projects. And we also had the opportunity to meet like a traditional healer, and we got to go to his house and see all his plants that he uses for medicinal purposes. And some of them sound possibly were maybe legit use of these plants. Some of them I really questioned. He had one like, if you put this leaf in your pocket, you won't get bit by a snake. So it's like a snake cure type thing. And so that one's like, well, okay, I don't know about that. But some of the other uses actually made sense with some of the plants he was using. So it was just interesting to, learn from him and see what he does. And now I'm just going to talk about how do we support and why. And, so there's limited faculty, family medicine faculty in Ethiopia. And so foreign government, so University of Calgary is involved, University of Wisconsin, and some other universities, along with the University of Montana, have been sending faculty over to Ethiopia. And I think that's going to be something until they're able to establish their own family medicine trained faculty members, if they're going to need this assistance. And so this is one way we're going to be able to support them. And not so much just always having faculty there. Maybe, our faculty might be going there in the future. Maybe there's probably give them different training courses. There's also, which is for obstetrics, for family medicine does, and also like neonatal resuscitative program, and offer different trainings like that for their residents. And I guess a reason why we want to help them that is because the biggest needs really in Ethiopia is in the rural areas and at these district hospitals, and just family medicine is going to be a very valuable component of that, just because they're trained to work with adults, with children, and do the obstetrics. And so that's going to be an important mission for that country. Moving forward, I think it's going to be important that Gondar University, particularly with our assistants with the University of Montana, express their goals and objectives. And we need to have clear communication with that moving forward. I think there's a goal for our residency faculty to continue to be going there yearly to do some training. And like I said, mentioned didactics and specific trainings. But I think it's important that moving forward that our faculty and our residency program and other institutions are going there to help, that they don't be that incubator. That's the big point I think that's going to be important, that we find out what the needs Ethiopia feels they have, and we meet those needs and not go in there with the idea of, well, we're going to offer this. We really need to make sure we communicate with them and see what they need us to help with. And I took a picture just of this donkey. There were so many donkeys, and it just represented to me like how stuff's just different. It's different in Ethiopia. This is in a city, and no matter in the city throughout, you would just see donkeys roaming all over the place. And it just shows you, just the life's different. There's different resources. But just because they have different resources, it doesn't mean that it's not effective. It was amazing watching these donkeys walk around. They'd have all these loads on them, and they're transporting goods across the city. And these donkeys are so well trained, at times there wouldn't even be someone herding them. You would just see a row of donkeys walking with a loaded pack, and they know where to go. And I'd be walking around, sometimes I'd see them walking back home. The donkeys didn't have to have someone walking along with them. So yeah, it's different. It's a different resource than we use, but it's very effective, and so we should just, value the resources they have and just help them use what they do have there. And I'm done here, and here's some of our references, and I'm opening up to any questions.
If anybody does have any questions, if we could, we'll hand the mic around so that, that they can be heard by everybody.
I know U of M doesn't have a nursing program per se, or it's out of MSU, but it just strikes me that that was a real missing piece to the exchange. Is there no, I know there's nursing faculty here. Was that ever considered? Or, and the reason I ask that is that I'm not sure that what they need is American family-trained doctors as much as an array of people with different trainings. Not to say that our physicians can't participate in that, but most other countries who have gone through this period have come up with a with a hierarchy of training, and I think it might be difficult to do what you're doing without involving nursing at the different, somewhere in there as part of the training.
Yeah, and I would agree completely with that. The MSU nursing program housed at University of Montana has actually been extremely actively involved in the interprofessional education things that we've been trying to work on through the university here. And they were, in fact, engaged and involved in this process. They weren't mentioned and weren't listed because they weren't able to participate in this particular trip. But yeah, we continue to have ongoing conversations because that's absolutely true. The issues of healthcare access in Ethiopia and the difficulty in terms of accessing high quality care are absolutely not going to be fixed by starting a handful of family medicine residencies. It's, as you mentioned, every level of healthcare, every resource. They're just completely understaffed. And nursing would be a big part of that. They didn't happen to take place in this particular trip, but they continue to be an ongoing part of that conversation. Yeah. Yeah, the MSU nursing program here that's housed on campus here has actually been extremely cooperative and very interested in participating with all of the other health professions here on campus. And so every process that we've had involved with trying to boost interprofessional education and interprofessional collaborative care as well, they've taken a very active role in that.
I was amused by your description of the interns, because that sounded like a perfect description of my internship 30 years ago. You've come a long way. And I would commend this project for working with the Ethiopians. It's the biggest problem we see in international health is little groups trying to go in and lay our thing on them. I have two quick questions. One is how much of an obstacle language was in this process? And second, one of the things that's been found in a number of the developing countries is that when you train physicians and they learn about what it's like to be a physician in other countries, they basically leave the country that trained them. Do you see that as an obstacle?
As far as the language goes, all their medical training is actually done in English. That said, they all learned English from each other. And so they had, their English has a very strong Ethiopian accent. So half the time you couldn't understand what they were saying even though it was in English. And they talked very quietly. And so when we'd be rounding, it was like almost at a whisper, which makes it hard to understand. And then with their accent, it was very hard to understand. So even being on rounds with them that was taught and being done in English, I mean, there would be times where I was like, I maybe picked up 10% was being said. So it is a challenge communication-wise. And also, I could never do an interview with any of, or like ask questions to any patients. All the patients live in rural areas. They're not educated like that, so none of them know English. And so I couldn't, I couldn't interact with the patients at all as far as getting any history. And as far as you mentioned about, trained physicians leaving, that's actually a huge problem. They have this huge, brain drain or whatever you want to call it, that term, because a lot of their physicians leave because they make very little money there and they can come to the U.S. or Europe. And so a lot of their physicians do take off, and if they get some training elsewhere, they just don't come back. So that's actually a big worry they have.
train your community health workers better, train your nursing staff better. They can do a whole lot of things on the family medicine side.
Absolutely, they can. And a little bit more on the point. One of the issues that's actually come up when we're talking about exchanges and collaborative efforts between the two institutions is there has been a very explicit mandate from the administration that's coming from the government at the University of Gondar that they will not let students come to the University of Montana to train. For that reason, because they're very concerned that if students, particularly young people who are still learning, come over and experience a lifestyle which has just significantly greater availability of resources, that it will contribute to and add to the exodus of people who are highly trained and do tend to leave in large numbers. And so they are very happy and request that we send them faculty, we send them students, we send them residents to participate over there so that we can share knowledge, and they will send faculty over who are invested and or have contractual obligations to go back and work to learn from us over here, but they're not allowing students to go over for those exact reasons. But you're right. Again, I agree. I think the things that we saw, particularly in the rural areas, were very similar to some of the situations I would see in Bush, Alaska, off the road system, where there just weren't the resources, and you couldn't get physicians out to these small communities just because they didn't have the population centers, they didn't have the resources available, and it isn't a valuable use of the limited resources that are there to send someone out. But in increasing the training and the numbers of the health extension workers, increasing the training and the numbers of the nursing staff, you absolutely can make dramatic improvements in terms of the improving the health care overall for the population. Our particular focus was on family medicine because we're from a family medicine residency, and that's one of the processes that they're trying to improve. Part of the idea of theirs, I think Justin mentioned earlier, is they have a very heavy public health focus in their family medicine residency curriculum, and this is a national curriculum that was put together in Audis with representatives from a number of different health professions. But part of the reason for that is because the anticipation is they'll have family physicians who will go out to some of these larger health centers in the rural areas, but will then engage in research and activities in public health to say, what are the resources we need in the even more remote, even smaller areas, and how can we improve the health overall better, knowing that we don't have enough doctors to get out to these areas in general. So yeah, that's definitely a part of it.
So given all that's been said here and given the diversity in cultures and resources and infrastructure, what's the level of enthusiasm in the students graduating at, I don't know, call it grade 12, and then facing a 6-year period of medical training and then going out into that particular thing? What's the percentage of people that are actually searching a medical career over there?
I don't have a good idea for like number of people seeking that out. I think it's a great opportunity, and I think people are really motivated in that country for opportunity. And it's a lot of it, I think it's based on like some test you take when you're finishing up high school if you can get placed into a medical school. It's not like I'm just gonna, like this is my second career, you know, I just kind of chose like I want to work hard to go this route. They don't really have that choice. It's kind of like, did you show you had this ability as a young man, young woman, and they give you the opportunity to do it. And I think because life is really hard in these rural areas, and I think if there's given an opportunity to be able to improve their life, so the ones that test well are going to have this opportunity, I think they're going to pursue it. I think the bigger concern, though, is for these rural areas is how are they going to attract people to want to go out there and practice or live out in those areas of any sort of training, medical, nursing, whatever it is, because if you grew up in Addis Ababa, the big capital city, where there's actually nice public transportation, there's electricity, good system, stores, malls, movies, stuff like that, and you grew up there, because I thought Gondar was a nice city. I thought it was like cool. It was like a very relaxed place, and most of the residents I met had actually grown up in Addis Ababa because that's a big part of the population, and they hated Gondar. It was so podunk, so little, so tiny, which was huge compared to the rural areas, but they just could not wait till they get back to Addis Ababa. So I think that's the bigger challenge as far as their healthcare system is convincing people to move out to these rural areas.
One of the issues that they have right now is in order to try and help make up for the healthcare shortage is after your first 6 years, you're actually required to do at least 1 year of government mandated service, and that can be up to 3 to 4 years depending on where you're located, and the government basically tells you. And so you get a lot of people who are actually just shipped out after their 6 years of medical school to these smaller areas, and then they're stuck working. So the district hospital we went to had 2 GPs who were working there for a population of 500,000 people. They had 2 GPs and 3 what they call house officers who are essentially, or health officers who are essentially mid-levels, PAs or nurse practitioner equivalents. And they were the people who manned this hospital. Occasionally they would get a surgeon who would come in and help, on a monthly basis or something, but really that was it. And so that's kind of where things are right now, and because the resources are so limited and they're obligated to go do that, they have a really hard time trying to convince people that that's where they want to stay. So for the people who are interested in furthering their education and their career, there's a huge push to go into medical specialties where they can, become procedure heavy because that's where they get more money, similar to the United States, although we're talking about orders of magnitude difference. And B, where they can be stationed in a bigger city. Once they've gone through residency training, then they do have the ability to pick where they want to go and what they want to do. And one of the common questions we had when we were talking with different departments about generalist training, family medicine training is, why would people want to go out to these rural centers? Why would they want to do a residency program to go out and work in these small little areas? That's going to be a huge challenge, I think, for many years to come until the infrastructure is built up in some of these areas that they become more desirable places to live. Yeah.
Government, just insurance. Do they have insurance?
No insurance at all. Actually, I can't say that completely. There is an increasing movement to have insurance, but for the most part, it's a cash-only operation where people just pay cash. But as point of comparison, for an inpatient stay, just for the hospital fee on adult medicine, for the internal medicine department, just the fees that they had to pay to stay in the wards cost a family about 40 cents a day. So they're paying, now for a farming family, that's a huge amount of money for them. That can actually be extremely difficult for them to come up to, particularly when you consider that they don't have the nursing staff, they don't have the support staff. And so not only is it the patient who's there in the hospital and the wards, it requires at least 1 and usually 2 to 3 family members to help care for them while they're there too. So the financial burden on some of these families who really have limited to no sources of income whatsoever, even if we're talking about 40 cents a day, can be extremely difficult because they have to come up with that money, but they also have potential income earners not working during that time while they're helping to care for the patient. Yeah, so insurance is just starting to come into play. It mostly is in the big cities. It mostly is when you're dealing with private hospitals and private physicians, and for the people who have a better income in larger areas that are taking advantage of it. But for the mass of the population, the general population, there's very little influence from insurance. Yeah.
I was just curious, my daughter was in Uganda, and we also made a trip to Cambodia. And in those smaller villages, we saw people who, some of the biggest problem was alcoholism or child abuse. Did you see that there, or was there a lot of alcoholism in those smaller villages?
Admittedly, we didn't spend a lot of time in the smaller villages, so I can't really speak on that. I know in the big hospitals, like at the Uganda Hospital, people aren't coming in there because of end-stage liver disease because of alcoholism. Most people are hospitalized because of infectious disease, so I don't know, I'm not going to say it's not there, but maybe, I mean, the biggest concern was infectious disease there at the hospital, but maybe that's because people are getting sick with those issues earlier on in age and struggling before the chronic diseases get to them, so I don't know.
Culturally, no. It's not an issue. In fact, for whatever reason, it's just cultural. There's very little alcoholism. It's beginning to grow and become more common in bigger cities, but in the rural areas, there's very little alcohol use at all. They do actually drink what they call beer, which is, at least smells like this incredibly distasteful concoction. But the alcohol content is actually extremely low in it. So it is an alcoholic beverage, but we're talking like 1% or less alcohol in it. So the amount of alcohol abuse is actually very, very low in the rural areas. One last question. We're running out of time here, so we'll take the last question and then have to call it quits.
The World Health Organization has shifted much of their emphasis to chronic diseases because now that we have solved some of the other problems that people are living longer. I gather from what you're saying that just isn't happening in Ethiopia. You're on infectious diseases and childhood diseases and maternal issues.
There's been a shift in Ethiopia quite dramatically in about the last decade, really. It used to be almost exclusively infectious diseases, but as of the time that we were there, they were telling us that about 50% of the adult cases that got hospitalized were actually due to chronic diseases. So they're starting to see significant shifts. This is actually interesting, and there were all sorts of wild theories we heard about this, because culturally, the people who are coming in with chronic diseases we're not living the lifestyle that we typically associate with chronic diseases. So there isn't a whole lot of processed prepackaged foods. There isn't the sedate activity throughout the day and jobs and things that we're typically associating with. And so nobody really knows why things are starting to shift. Even in the rural areas, we're starting to see more and more of the diabetes, of the heart disease, and those sorts of things. So the numbers are changing, and they're putting a much greater emphasis on, but it's still about 50-50 right now. Absolutely, absolutely, yeah. So when you're talking about chronic diseases that you're having to manage on an ongoing basis, having higher trained physicians in those rural areas and easier access will make a huge difference. The infectious disease processes, obviously, it's much simpler to have a protocol to say, someone comes in with this infection, you give them this medication and treat them for this long, and then they go on their merry way. So yeah, agreed. All right, well, thank you very much for coming. We're running just a little bit over now, so if anybody does have any other questions, we can stick around for a couple of minutes and chat one-on-one. And if anybody is interested, we are planning on continuing this relationship and continuing to work with the program in the University of Gondar, both through in general and all the disciplines, the health professions there, but specifically our residency. And we're more than happy. We're coordinating efforts with a number of other groups across the United States and in Canada, and we're more than happy to talk with people who might be interested in helping out with that process. Thanks.